Welcome to another episode of Empowering Prosthetics, Empowering People. My name is Bob Radocy.
And I'm Debi Latour, and we are here to talk to you about empowering you as persons with hand absence or impairments.
And my background is as an engineer and designer of prosthetic components. I've been doing that. I did that for over 40 years. Started because of an accident I had in 1976. Debi's story is a little different.
Yeah, I was born without my right hand and started wearing and using prosthetic devices when I was 1. And since that time, I've continued to use different kinds of prosthetic technology. I became an occupational therapist in 1978 and have enjoyed 45 years of being an OT. The last 25 have specialized specifically in prosthetic rehabilitation.
Yeah, our primary aim is to provide you with information. We want you to become advocates for yourself, but provide you with information to make you a better consumer. So we've talked in the past episodes about different types of technology and socket designs and terminal devices. With this presentation today, we're taking in a little bit different direction, talking about rehabilitation.
And that process. Our aim is to really equip you with this information and to engage you actually in a community of persons who are listening to these episodes. The ultimate goal is to empower you and those around you, your family, your caregivers, and even your practitioners with skills, strategies, and even tips and tricks. So again, we want to empower you. And who are you? Well, we're talking to you as persons with upper limb absence, or maybe you still have your hand, but it is not as functional as it once was. We also want to empower your families and caregivers with accurate information and provide support to your medical and healthcare providers. Why is this important?
Well, as an informed consumer, you can help ensure that you're going to get the prosthetics technology that's most appropriate for yourself. That's one of the primary goals, certainly.
Yeah, and to be able to better self-advocate. We don't know what we don't know. So if we can access accurate information that's actually helpful and relevant to our needs, it allows us the opportunity to better speak up for ourselves and for those we care about. Also through this, the hope is to engage you with peers and help you to be more knowledgeable about resources that are available to you. These videos will also help to give you experience and information so that you have improved participation and even performance in some of those activities that are meaningful to you. Ultimately, it's to enjoy a positive quality of life.
Exactly.
Like what I think each of us have.
Exactly. So this is just a little review of where we've been, and this is going to be into episode 5, I guess we are.
And we just want to let you know, so today we're going to talk about this rehabilitation process, specifically focusing on teams and phases of care. So when we talk about rehabilitation teams, these usually consist of what is referred to as patient, or a word I like better, client-centered teams. So that means that they focus on you and your needs. They're made up of a team of specialized professional practitioners. Unfortunately, for persons like us with upper limb absence, these teams are few and far between. This information is highly specialized, and because technology changes so quickly, it's often hard for practitioners to stay in tune with all of the most recent developments. Don't you find that to be true? Yeah. And your rehabilitation team also consists of meaningful others in your life. Maybe your partner, your spouse, your children, if you have adult children especially, parents, any other caregivers or family members, and also potentially peers. So there might be some of your friends or other supports who become part of your team because they're helping you to advocate for yourself. And oftentimes these other people who know you best can help you think about things a little differently. Think about the information that you're receiving in a different way.
And this is especially important if you have, let's say, a newly acquired hand loss or trauma. Having these teams and having cooperative relationship between your peers, your family, your physicians, your therapist becomes very important. It's not, as Deb was saying, it's not always available to everyone, and in some cases you have to, advocate for yourself to try to reach out to see if you can get that kind of input, if it's how you can make it available to yourself.
Yeah, and similarly, if you're a new parent or a parent of a young child who was born with a congenital limb difference or even had an early acquired limb loss. So sometimes things happen early in life. There might be vascular incidents or others, and a child might lose their hand at an early age. Finding resources can be really challenging. And you'll find that most of the information is oriented toward persons with acquired loss. Those of us with congenital difference, oftentimes we have to take that information and apply it to our needs. So we're presenting two different perspectives of what that rehab process might look like depending on whether or not your situation is with an acquired difference or if it's an acquired loss. Congenital difference or acquired loss.
And it's a process. It's a step-by-step process, and it includes some important components that Deb can describe.
Yeah, and I think the most important one is communication, and being able to not just state what you need or figure out what you need, but as we've talked about in some of our past episodes, that importance of listening and being an active listener. So having practitioners who really hear you and hear what's meaningful to you, hear what you want to accomplish so that they can help you achieve those goals. So communication is one. Another is a concept I like to call the 3 E's. It's really how I frame them, and it includes education, empowerment, and engagement. So if we can inform you with important material that's relevant and meaningful and accurate, not something off a website that's promoting a particular product, but something that is really non-biased, right? That was what we were trying to do in this series, was give unbiased information. So really inform you, and then engage you in this process by giving you tips, tricks, strategies, even questions to ask your practitioners, engaging you in this process, and thus that empowerment so that you can be a better advocate for yourself or your family members. And all of this does take a team approach. And we talked about the client-centered approach that's focused on you as an individual, but you'll also hear some other words that can be very confusing because they often sound similar or the same. So one is multidisciplinary. And multidisciplinary I like to equate to I like to use visuals. So have you ever looked at a bicycle wheel and you see how there are spokes? And in some of the older bicycles, those spokes all came from the outer part of the tire in toward the center, all right? They didn't overlap or anything like that. They just all moved toward the center. So that's a great visual for a multidisciplinary team. But then we have the term interdisciplinary. And the visual I like to use with that to help explain it is that same representation of the bicycle wheel, but in more modern bicycles, you see spokes where they start to overlap with each other. So that's kind of like an interdisciplinary approach where maybe the PT and the OT are actually talking together and co-treating, or maybe OT and speech, or a social worker might come in and overlap with someone else's duties or responsibilities, so that you're getting information as the client, you're getting it from a melded perspective.
And you're the hub, you're the center
right,
of that.
you are
one,
the center.
Yeah,
because it's all about you.
Right.
But then the last one is really more modern and contemporary in our current society. It's one that, I'll confess, I'm an educator and I teach my own students. And it's referred to as collaborative interprofessional. I maintain a small therapy practice where I work specifically with a prosthetic practice, and we employ this very concept of collaborative interprofessional. So I don't use the bicycle wheel model for this to further describe it. I actually think about smoothies. Have you ever eaten a smoothie?
Absolutely.
Okay, or do you drink it? You don't really eat it, right? We drink it. So if you think about a smoothie, we could take the same 5 ingredients, right in front of us, and each make our own smoothie, and they could come out totally different. even using the same 5 ingredients, because maybe I'll use more of one and less of another, and you'll choose a different combination.
Right.
But all
Mine
of
will
that,
be better than yours.
You think so? Okay, we might have a challenge later, okay? Pull out the blender. But that's what a collaborative interprofessional practice is, because that unique combination of ingredients is relevant to you and your needs. It might consist of the same practitioners, OT, a physiatrist, a surgeon, a prosthetist, a PT, even a social worker, and maybe peer reinforcers, persons who have walked this way before with limb absence. But what your unique needs are will determine how much of each of those ingredients are going to be beneficial for you. So I like that it presents a more individualized component. So we've talked to you a little bit about this comparison with persons with acquired loss and persons with congenital difference. And if you think about it, our rehab process is very similar. It's just that it occurs at different points in time. So for a person with acquired loss, I'll talk about that one first. We can both share that a little bit, because that's actually the majority of the population. When we look at the adult population, it really consists primarily of persons with acquired loss. If we're just focusing on persons with limb loss, the acquired loss is the larger percentage of that pie. Sometimes persons with acquired loss, most often it's due to trauma, but sometimes there's actually a planned event where the amputation itself is planned. It's mostly related to a disease process, or if someone needs a revision.
Or severe injury sometimes, which the hand or the extremity can't be rehabilitated. Then you go into an elective amputation, but
Sure.
it's not something that's an immediate trauma like a car accident or something
True.
like that. It's a planned surgery.
Right. So during that time, that preparation before an amputation, if the person is blessed enough to actually have that opportunity, they can become more informed with a team that can help to prepare them for what's ahead. That might be the times that we introduce concepts to help do some very basic self-care and explain to them what the prosthetic technology is likely to be that would be relevant to their limb level. And then, of course, the amputation occurs, and there's rehabilitation that needs to happen that's related to wound care and whatnot. We'll go into that in a few minutes. There's an acute stage where then it's a little bit prolonged in that we need to wait for some wound healing, but we begin to prepare that residual limb for a prosthesis. And then there's a post-acute stage where there's active therapy and prosthesis use for most people. Those are the general phases. For someone with a congenital difference, it's a little different. Certainly when a child is born to parents, these days we actually can see that on the ultrasound, and the parent can prepare for that, and the neonatal team can help them. Way back in the day when I was born, I think it was a little bit of a shocker for my parents, because we didn't have internet for resources. We didn't have the technology for seeing something like this ahead of time. But in terms of pediatric care, we often engage in early intervention, which includes early fitting. It includes really looking at the child's developmental milestones and acquisition, engaging them in prosthetic training as early as possible, especially if it's within the realm of the parent's culture, the family culture, and their goals for their child. And oftentimes, because children grow, and we certainly hope that they do, right? They often need reevaluation and assessment for new technology and new ways of doing things, because sometimes when our bodies change, we can't continue to do things, the same tasks, the way we used to.
And a child being fit very early on with a prosthesis not only helps the child be more functional and develop more symmetrically, but they also integrate that prosthesis into their body image. So, they can certainly perform unilaterally if they don't have a prosthesis. But if they have a prosthesis and they learn to use it, it can be used for balance and for crawling.
Transitional
but also
skills.
bilateral control. They start to integrate it, and they grow up looking at basically two appendages instead of one with a, with a limb absence on the other side.
When we talk about prosthesis use, oftentimes we consider, the likelihood of rejection. It happens, unfortunately. But then some other really important aspects of prosthesis use include, of course, acceptance of the device into their routine, but even more so into their body schema. And that's where it lends itself toward embodiment and concepts of embodiment that are still being studied. And I always find that interesting because as a person who has used a prosthesis since the age of 1, so going on 67 years, I certainly like to think that not only have I accepted my prosthesis, I can do everything with it, regardless of which one I'm using, and I can do everything without it. But I clearly have embodied my prostheses, every single one of them, and incorporate them into my sense of self. I'm always talking with my hands, and I'm always referring to myself as two hands, even though I clearly don't have it. It's not denial. It's just a unique form of acceptance and embodiment. Do you have something similar?
Yeah, I wear a prosthesis virtually all of the time, other than sleeping and bathing, and it's a part of my body. If I'm not wearing a prosthesis, it makes me feel a little bit naked. Actually, I feel less proficient, less ready to deal with the world if I'm not if I don't have a prosthesis on.
Yeah, I feel the same way. So this is totally off topic a little bit, but since you opened this can of worms, how do you feel like going to the beach? And I mean, do you swim with a prosthesis on, or do you go to the beach without a prosthesis?
I typically go to the beach with a prosthesis. I take it off while I'm at the beach. In certain cases, I'll swim with a custom swimming prosthesis, but in many cases, if I'm just wading or bathing in the ocean, I'll take my arm off, and you draw a lot of looks because it's unusual. But
you're looking for the shark bite.
Yeah, you become used to that, and it just becomes part of your life.
And regardless of whether people are looking at us with a residual limb or looking at us with a prosthesis, these can become teachable moments, which as we embody it, we almost embrace that as part of our, mission or ministry in life. All right, so we just talked about those general phases of care. How does the collaborative process actually fit into that? So during prosthetic preparation, we can work as a team, and I'm often working with a team of prosthetists, and we explain a lot of the technology to our clients or potential clients to better inform them. And we always include that family members come because oftentimes they hear things that we don't. I know when I go to a physician, I'm often
you can be overwhelmed sometimes by the amount of information. So having a peer or family member can help also listen and reflect back on what was said during the conversation.
Absolutely, absolutely. And that prosthetic preparation can include things like when the person's in the hospital, a visit from the prosthetist explaining some of the process itself, because these are not devices that we just go to a store and buy off of a shelf. Right? It's not really a one-size-fits-all kind of thing. It's always individual components and figuring out what's a good match. So that takes time. And it's not even like it's a mail order. We have this whole unique process that we have to go through to better understand the technology and better understand our client needs. So that includes a consultation and then an actual evaluation where we're looking at, well, I as an OT look at pretty much everything. I consider the past medical history. I like to look at existing function, which most people just think of as being range of motion, coordination, strength, perception, like sensation, and stuff like that. But I'm looking at it, first of all, for both upper limbs. And I'm also thinking about what else is going on in my client? What comorbidities do they have? Do they have any past injuries that include fractures of their available body parts? Or especially if it includes a brachial plexus injury or any kind of shoulder injury on the opposite side.
Could it cause a range of motion restriction or something like that?
Sure, it could affect the prescription and what we might, and how we justify what our recommendations might be. And then I like to also consider what else is going on with my patient client. What is their home and their work environment?
What's their motivation like? How interested they are in a prosthesis? How excited they are about it? Assessment comes in a variety of different forms. It comes from the purely physical assessment of what you can actually do, but assessments about motivation and mental.
Anecdotal.
Yeah, exactly.
So important.
And they all kind of combine to help your medical professional provide you with the best possible technology. It extends in even to, like, what are your hobbies? What's your vocation? What are your hobbies? What would you like to do in the future?
Exactly. And what is your learning style? Because if I'm going to be teaching someone how to use any one of a myriad of diverse technologies, I want to understand how you best perceive that you learn. Are you a visual learner? Would you rather read about things or trial them, or go off in your own corner and practice and then come back and show us what you've learned, and then we build on that? So everyone's different. So figuring out what makes each person tick is really part of that evaluative process. And then we can get into some pre-prosthetic training. So believe it or not, from the time of the evaluation until the person receives their prosthesis, there's a lot happening behind the scenes.
It can involve months of time.
I know, it's so daunting. And we're going to talk about that in a few minutes. But we can use that time to actually capture a person's excitement and enthusiasm for learning to do things. One of the first things we do is make sure that they can use their available anatomy to complete tasks. So if they lost their dominant hand, it means actually transferring that hand dominance. It means getting that residual limb ready to tolerate a prosthesis. And sometimes, with the use of some technology we'll talk about in a few minutes, it means actually starting to better understand the actuation of a prosthesis and starting to apply it to some simple tasks. Many times the prosthetist will deliver a prototype device once they get that insurance approval, because that's the other thing that happens. Once they get that, they can start making the device. And when they do that, it gives the person, the user, an opportunity to try it and see it, what they like about it, and what hurts, what doesn't hurt.
Yeah, and communication at that stage is very, very important, and you need to have a good rapport with the person that you're working with, the prosthetic professional, because they need to understand, they can't tell how that prosthesis socket, that prototype, feels on you. You have to express it to them. So you put load on it, you move it around, and if you have pressure points or if there's pain in certain areas, those are things you have to communicate, and that gives the prosthetist the ability to go in and modify that interface, that socket, or that prototype, to get it to where it's a better fit for you individually.
Yeah, it's probably the most important time, because this is the time where change can be made to that device. Okay. Once it's turned to a permanent status, it's very difficult to make any changes. So that is really the consumer's time to really speak up. And that brings up a really interesting point, because most prosthetists are artists in a sense, right? They've created something, and they're usually very proud of it. And we as human beings are always conscious, or often conscious, of not wanting to hurt someone's feelings. So I know I've been in the situation where especially early on, as a young adult, feeling uncomfortable telling someone who cared so very much about this device they just were trying on me that it didn't feel good, or that I didn't like it. There was something I didn't like about it. It was hard to do that.
It's important to do that. It is important. You just again, it's advocating for yourself,
right,
to get the best outcome.
Right, and by doing that, you're not hurting their feelings. You're actually making it something that's a product you can use. Because the last thing anyone wants is for any of these devices to just be laying on a shelf, or, I don't know, on the floor of your closet.
Not being used as often as they could be. Yeah.
Right, right. So that's the time to speak up, is during that prototype stage, before that definitive final prosthesis gets to you. And then you can engage in some active prosthetic training, and then later refining those skills. So how do we actually prepare someone for a prosthesis? So that's the time where, if there's any wound healing, if there's been an actual loss, preparing that healing area, often desensitizing it, watching how that scar tissue is developing, and making sure that there are no adhesions, and making sure that the tissue around any scarring is actually mobile. So working on that. For anyone, whether it's acquired or congenital difference, working on desensitization is important because you're going to have your residual limb in a confined area in that socket. And I like to refer to the socket as being the most important part of the prosthesis because that's where we have that intimate fit, right?
Yeah, and if you're in a traumatic loss, this will all be initiated while you're having hospital care. If you have a traumatic loss and have an amputation, you're going to have swelling. There's a lot of things going on in your body as your body heals itself, but you'll be coached along on these early stages with the kind of care that you need. And then when you're released from the hospital, when you go home, then there'll be guidance for you as to how you self-care, and then you'll have regular. Typically, if everything is done in a team type fashion, you'll have regular interaction with therapists and prosthetists as the process moves forward to make sure that you're just on track and you're moving safely forward and with health, towards a prosthetic rehabilitation.
Right. It disappoints me a little bit to say this, but many times at this phase, when you as a person with a newly acquired loss are dealing with that, but also trying to do things for yourself, right? Some tasks are just so personal, and our sense of independence and positive self-esteem are tied into it. So some of them are being able to cut our own meat, for example, being able to toilet ourselves. That's a pretty personal task, and to have to ask for help with that as an adult can be really confounding and discouraging. And that is a time when occupational therapy practitioners can really help you. And if they aren't proactive with helping you, please demand it. That's their job.
And it's the acceptance of the circumstance. So I'll tell you a quick story. I was in an accident in 1971 and I crushed my forearm, wound up being in the hospital. Well, the surgeon came in and my arm looked like the size of a balloon, and it was all bandaged up. And it was the second or third day, and the doctor came in, the surgeon came in and unwrapped my arm, and I turned my head away because I didn't want to look at what was left of my forearm at that point. And very nicely, but very, very strongly, he said to me, "Bob," he goes, "you need to look at this. You need to deal with it, and deal with it now. And start to understand how the rest of your life is going to go on." And by doing that, he helped flip that switch. And I did deal with it, and I moved through it. And so you need to have that positive attitude. You have to be able to accept it. It's not always easy. Everybody goes through different levels of emotional, recovery. But if you can deal with it, it helps you just move forward that much better and that much quicker.
Absolutely. And one of the best ways that we can do that is to engage you in that process by having you engage in some of that self-massage and learn to change your wounds or apply a shrinker so that the residual limb can be shaped in a positive way to be able to tolerate a prosthesis in the socket. Oftentimes, practitioners are so focused on the loss that it's easy to forget about those other needs that you have. So certainly those psychosocial needs are going to be preeminent, but some of those psychosocial needs, as I was saying, are tied into your physical function. So being able to learn to use your opposite hand as a dominant hand, or learn one-handed strategies, even if you still have retained your dominant hand, those are important elements to be included as part of your rehab process.
Yeah, one of the philosophies that I picked up at that time that was popular saying in the 1970s was, "Today's the first day of the rest of your life." And that was something that I took on, and it was just a good philosophy, looking forward to every day for what it was and then moving on.
Yeah, it's almost like being in kindergarten again, right? In kindergarten, you really liked school. You got excited about it. And then by first grade, you kind of thought, oh my goodness, I got 12 more years of this, right? But when you embrace a philosophy with a positive attitude like that, it can make such an incredible difference.
It does, certainly. It did for me.
This is also a time when people might engage in counseling, but even as important to that is utilizing peer resources. So often prosthetists will ask you if you're interested in meeting someone who had a similar experience or is using prosthetic devices so that you can learn more from a little more objective perspective. This brings us to the philosophy that happens. I think it was a gentleman by the name of Malone. I wish I could remember his first name, but he came up with this concept many years ago of the golden window. Yeah, and the golden window refers to a study that was done, I'd like to say it was actually in the 1980s. But what he found was that persons with limb absence, particularly acquired loss, if they were able to acquire and use a prosthesis early on, like within 30 days, that they would actually have better outcomes. So not only were they able to learn to use their prosthesis easier, but they accepted it. There's no study that says that they embodied it, but it does say that the acceptance rate went up very much, whereas persons who received a prosthesis later than that had a higher rate of rejection.
And one of the things we've discovered, and Deb has done some research on this clinically, is that we've developed prosthetic simulators. And a simulator can be worn by someone who has hands, and it replicates the function of a prosthesis. And what Deb has found, we initially developed these for training therapists and prosthetists, but what Deb found is that she could put a simulator on the unaffected side, the sound side of someone who went through a recent trauma, and not only expose them to the different types of technology and how it works, but actually get to train them on the sound side. And what we realize is that you have crossover training. You start to understand how a prosthesis works, and then when the person gets their actual definitive prosthesis, they've already have it in their brain as to what it's going to sort of feel like and how it's going to operate.
Right.
And it can accelerate someone's rehabilitation and get them excited about that rehabilitation, about the acceptance of their prosthesis as well.
Yeah, absolutely. I think it's important to mention that these prosthesis simulators are available in both pediatric size as well as an adult size, which is really pretty cool. I get excited about the prosthesis simulators because I think about all of the different applications. And most importantly, it's because they help us to avert the black hole. So I talked a little bit about the golden window. The golden window is really like the optimum. It's gold for a reason. It's like a gold standard. Unfortunately, here in the United States, insurance companies actually seem to drive our health care, including our access to prosthetic technology and reimbursement for it. They can't meet that 30-day window. I mean, when do we get authorization? I think most insurance policies actually say 30 business days, which if you calculate that out without holidays or vacations, 5-day working week translates really to 6 calendar weeks, right? Yeah, that's pretty daunting. So that means we're already, according to Malone's theory, we would be putting people in what I call the black hole instead of that golden window. So being able to introduce people to prosthetic technology early, despite actual authorization, can lead to a positive outcome because we're using that time wisely. Before we can get to that point where we can really introduce those simulators, we need to have a consultation. And that's where we can really impact you and arm you, no pun intended, well, it was an intended pun. We can arm you with information that is important and helps you to better understand the technology, helps you to understand the impact of your residual limb level, with or without a prosthesis. And I think that's important. We can actually use that time to have you trial the devices with the simulator and even setting up other kinds of simulated circumstances. These kinds of experiences allow you to have, oh no, another pun, firsthand experience, so that you can compare the benefits and the challenges that you as an individual might experience with these different technologies.
Yeah, we've talked in the previous episode about different types of terminal devices and if they're body powered, whether it be voluntary opening or voluntary closing. And those are all things that come into play, trying to figure out what may work, optimally for you, or combinations of them, because you're not locked into any one technology ever. You can use different technologies, and especially here in the United States, they promote the ability to have more than one prosthesis. So you might have an electric hand, you might have an activity-specific, body-powered hand. That's not true everywhere in the world, but here we're pretty progressive that way, and we're trying to provide, the healthcare systems try to provide people with lots of options.
Right, and that's because there is substantial evidence that points to the fact that not one prosthesis can replicate every function of the human hand. And when you think about our human hand, we've got a soft palmar side, right, that's capable of embracing and intimate gestures, right? And then we have a hard side that's bony. We are capable of resistance and pushing and pulling. We're also capable of very fine dexterous movements. So it does often take different devices. And most people do not access multiple devices all at once. Most insurance companies will only pay for one prosthesis a year. So picking out the perfect first prosthesis is important. It's important for your success and for us to have, as practitioners, to have a successful prescription for you.
Yeah, so you get the best outcome.
Right, and then we can build on that subsequently with other devices, because we can see how you use that device and then what else you need to help meet your needs. So this all works together to helping you as the consumer be more informed and have more realistic expectations from the devices. So I like to remind people that knowledge itself is a process, not a product, right? It's not about necessarily the end. It's not that we're going to have something at the end. It's about what we learn along the way and what our whole journey is.
And continue to learn, yeah.
So this slide offers to you some considerations that if your prosthetist or your therapist don't ask, you should. You should be informing people about what the requirements are for those meaningful tasks and activities that you would like to engage in and maybe are required to engage in during the course of your day. You want to think about and share what are the environmental factors. So where are you performing these tasks? Is it an environment that's very hot, which means that you're going to sweat a lot, and that could impact your prosthetic technology and even your use of it? Is it dusty? Are you doing tasks that are incredibly robust or more sedate? So sharing that information is very important. Understanding the advantages and limitations of each device is important, and understanding the actual limits of the technology, what the manufacturer restrictions on it might be.
Yeah, we're far stretched from the Luke Skywalker, bionic arm. And like Deb was saying, there's multiple devices that'll help you in your life as you move through.
Yeah. Another important consideration is, how does the prosthesis, wearing and using the prosthesis, will it impact my functional range of motion at all? So some considerations might be, how does the harness affect use of my shoulders, or the style of the socket? Is it going to limit my elbow flexion or extension? And understanding that can help us to have realistic expectations too. Understanding how the prosthesis is going to hang or suspend from our residual limb.
Yeah, getting exposure to that and building a tolerance to it, because a prosthesis is like wearing, in some ways I'd relate it to wearing a new pair of boots or maybe putting on new shoes. You have to get used to it. Even though it might be a very good fit, there's some tolerance and skin things that are going on, and just getting used to wearing it and what it feels like can be a process that could take, might happen very quickly, it might take a little while.
Right, right. And being able to find out what other technology options are available. So being an informed consumer. We've talked about some of these. We talked about quick releases just in a previous episode, as well as even showing how different manufacturers are willing to work with their consumers to help them have modifications or adjustments.
Right, and some processors are more talented at others, and they can do more unique custom work for you that you might need. And it's not true across the board, but there are people out there that are talented. And the ultimate goal is to try to give you the best prosthesis to allow you to perform at your highest level.
Yeah, one of the questions that I often ask when I'm about to get a new prosthesis or try something new is, what kind of support does the manufacturer give? Are they going to send me a loaner if it breaks? Are they going to warranty their actual product?
Build it so it doesn't break.
Build it so it doesn't break. So let's get to the exciting, fun part before we end this session, and that's those prosthesis simulators that I just find so much use for and so much value in. So prosthesis simulators themselves have been around for a very, very long time.
They were mostly designed for student learning and as for students to practice and understand what a prosthesis was about. But they have a far broader and more useful ranges of use than that, as Deb has found out.
Yeah, because we can use them so that people better understand the technology, but also understand the impact on function, and that helps to develop empathy. So if we can not only have our consumers use these, but we can have caregivers or practitioners,
family member or peer
members
actually put on a simulator, and then they understand what their brother or sibling or cousin or child is going through, and it helps them learn, and it just helps with the overall process.
Right, even case managers or those people behind the Wizard of Oz curtain at the insurance companies who are making the decision about reimbursement. Having them try one of these on and actually try to use it to tie their shoes or cut their meat can really speak volumes into prosthetic care.
Direct personal experience and what it takes, amount of energy and concentration, and the outcome of using a prosthesis.
So thinking a little bit about historically how these simulators have really evolved, not just in their design, but in how we interpret information from it. So there was someone in 1968 named Bitterman who did a study and used simulators with persons who had not lost a limb and collected data on how did a person use, with two intact upper limbs, learn to use a prosthesis simulator. And that information was then used at the time to help support prosthesis use. Well, it wasn't until about almost, 35 years later that Weeks did a study, that was in 2003, and he used the prosthesis simulator on the uninvolved side with the idea that then could people transfer their skill. They learned to use the prosthesis simulator to complete some simple tasks, and then when they got the prosthesis, could they transfer that knowledge to their opposite side? And that was used to help reinforce prosthesis use.
Exactly.
And more recently, I've reported on it, and even others have piggybacked on these studies and just used the prosthesis simulators in preparation for functional benefit at delivery. So I want to tell you a quick story. So this prosthetist called me because he had received a call from a person in the community who was not a patient or client of his. And this young man was interested in activity-specific devices. Okay. He had lost all 4 limbs at the age of 11 months due to typhoid in another country. And he had very long residual limbs. Like, I don't remember the exact levels, but they were close to the wrist. And he might have even had partial, just beyond at the time. But in any case, he had tried a prosthesis as a child, and he didn't like it. It was a split hook, whatever. And it didn't match with his culture. And now he is, appearing 45 years later with very different functional needs and was interested in an activity-specific device. But the problem was he had no insurance. And the prosthetist said, well, I'm sorry, I can't just give these devices to you. They're going to cost me money. Can you sign up for state insurance and maybe we can get something covered? So it took 6 months for this gentleman to get accepted into the state system for insurance.
And you used the simulators to prove that he could be functional with a prosthesis.
Right, once he got insurance. So what happened was he came back with insurance, but the problem at that time was that the insurance that he got would not cover activity-specific devices. They viewed it as recreational and not functional. So that's where we started coming up with those crossover functional devices. But this is where it gets interesting. When he showed up saying, I have insurance, and and we went through that process, I had just gotten the simulators from you, and I brought them to the visit. And I said, why don't you try these? And he had not been open to body power prosthesis use at that time, but he was willing to try the simulators on. And we started by putting one on one side and then putting one on the other so that he could have bilateral function. And we let him try the split hook, which was what he was familiar with, but had already said he didn't like. And then I showed him voluntary closing, and he tried that and thought it seemed so natural. So we decided, I worked with the prosthetist, and he put forth a request for authorization. And in the meantime, I had this gentleman come into the hand therapy practice where I was working, and I brought the simulators into the hand therapy practice, and he began to learn to use them. So that by the time his prostheses, 2 of them, were delivered to him a few months later, he could zip his own boots independently. He could open and close containers. He could zip his jacket, and he could cut his own meat.
Accelerated his rehabilitation.
Right. He didn't need therapy after he got the simulators. Yeah. In fact, he agreed to it just for some refinement, and then no-showed me 3 times and said, I've got this figured out. You taught me the tricks to be able to apply this to other tasks. And that was because of the simulator. So
that was probably very rewarding for you.
It was incredibly rewarding for me, because not only did it help to get his devices approved by the insurance, because we had made videos of him with the simulators, but then I was able to engage him in prosthetic training on a preliminary, a preparatory fashion, and he was successful coming out of the starting block. So yeah, it was super exciting. So what are these simulators anyway? So here's a great picture, 2 of them, and they show the simulator, how it can attach onto the residual limb or forearm.
It's a sleeve. It's an adjustable sleeve that slides up and over the forearm and has a mounting system, so you could place a variety of different kind of terminal devices on it, and so that it literally, the word simulates the use of a true prosthesis. But it's adjustable. The ones that are produced now are soft and flexible. You can heat them up and quickly mold them to someone's forearm and then remold them to be used by a different individual.
And the harness is adjustable, highly adjustable, with all of the buckles.
All right, so we could fit someone with a prosthesis that may be 250, 280 pounds, or we could also size it down to somebody that might be 90 or 100 pounds.
Sure, that's great. And it can accommodate both voluntary opening and voluntary closing terminal devices, as well as activity-specific.
Activity-specific as well.
Yeah, so it just has so much opportunity for unique application. In persons with bilateral absence, they can even use one VO on one side and VC on the other side to really experience the differences. Anyway, it helps people better understand not just the use, but how it works and how they need to change the load on their own anatomy to be able to accommodate for it, and develop their own unique motor planning strategies to complete tasks. So I think that wraps it up for this session. I hope that you'll return to us and stay tuned for our next episode, which continues with rehabilitation processes, but we're going to talk a little more about the actual evaluation process and interventions that we might use.
And as always, we really encourage you if you have questions, you have any comments, you want to contact us, we have contact information behind us. So yeah, please take advantage of the fact that we're out here. We're resources to you.
Right. We're looking forward to your questions and hearing from you.
See you next time.